This one bedside finding could mean something very, very bad. Think stroke, not an ear problem. Let's talk about the HINTS exam. So when someone comes in with continuous vertigo and nystagmus, you need to know, is this just vestibular neuritis or is it a posterior circulation stroke? The HINTS exam can be more sensitive than MRI in the first 24 hours. So this is a really valuable test. What is it? So it stands for head impulse, nystagmus, test of skew. I like to rhyme because I think it's all hard to remember. So remember, turn the head, watch the eyes, cover one, and see who lies. So the head impulse is the first part. Turn the patient's head quickly side to side while they fixate on your nose. If they have a corrective saccade, think peripheral. If they have no saccade, think central cause like a stroke. The second step is nystagmus. Have the patient gaze left and right. If they have unidirectional nystagmus, think peripheral. If they have direction changing vertical or torsional nystagmus, think central. The last step is test of skew. So have their gaze fixed ahead and cover one eye alternatively. If the eyes stay aligned, think peripheral. If they have vertical correction, think central. I'm going to rhyme again for you guys. Normal head, changing spread, skew instead, stroke ahead. Any one central finding in the HINTS exam is a stroke until proven otherwise. What are the peripheral causes of this? Think about the ear, the labyrinth, and the nerve. So it can be BPPV, vestibular neuritis, can be Meniere's disease, labyrinthitis, or even otitis media or a vestibular schwannoma. You can also get it from alcohol intoxication, and this is the classic cause of acute vertigo and nystagmus, and honestly pretty relatable, right? Central causes, think brainstem and cerebellum. So this can be an ischemic or hemorrhagic posterior circulation stroke. It can also be MS plaques, tumors, even a migraine with brainstem aura. If you have a high suspicion for BPPV, you can do something called an Epley maneuver. It's so useful for these patients to get them in and out of the ER. So the patient starts seated with their head turned 45 degrees towards the effective ear. Then you quickly lie them back with their head extended about 20 degrees, even like reverse Trendelenburg them. This is the Dix-Hall pike, and wait for the vertigo to resolve. Usually it's about 60 to 90 seconds. At that point, then you want to rotate the head 90 degrees to the other side and hold it about 30 to 60 seconds. Then roll the patient further onto their side with their nose pointing toward the floor and hold again for about 60 to 90 seconds. Then you can sit the patient up slowly. And here's another rhyme to remember the steps. Turn, drop, roll, sit, BPPVs, done with it. So remember, if your dizzy patient has a normal head impulse, direction changing nystagmus, or skew deviation, it's probably not the ear. It's a posterior stroke and you should not miss it.